Hello, class and professor. I'm Solange Peniche, and today I am discussing the social determinants of health implicated in the TSD3 case study. Key social determinants of health affecting Tony. According to the Centers for Disease Control and Prevention, social determinants of health are the conditions in which people are born, grow, live, and age, and include the domains such as economic stability, neighborhood-built environment, social community, context, education, and healthcare access. Let's explore further the SDOH domains embedded in Tony's case study. Economic stability. Tony works at a low-wage job and is saving for college, but can afford some basic comfort, such as air conditioning. Built environment. His housing is suboptimal. No windows, hot apartment, which can affect health directly, heat exposure, sleep disruption, and indirectly stress. Nutrition. His diet is constrained by his job setting and budget. Frequently eating fast food, leftover meals may increase the risk of hypertension. Social context. Death of family 80 years ago. He lives alone. Minimal social engagement that increases risk for isolation, grief, and poor coping. Healthcare access and literacy. He hasn't had the regular preventive care, only recently gained insurance. He is unclear about what high blood pressure means. Now, I would like to discuss how social determinants of health affects health outcomes. Social determinants of health plays a significant role in influencing patients' health. Tony's health status shows probable early cardiovascular risk, newly documented hypertension, visiting the ER recently, and he now complains of persistent headache. The combination of an unhealthy diet, a stressful work environment, hot, poor housing, and limited social support creates a milieu in which hypertension is more likely and harder to control. Apparently, his healthcare utilization is suboptimal. He hasn't seen a provider in 5 years, which means missed preventive opportunities. The ER visit signals that care was reactive rather than proactive. Regarding health disparities and barriers, lower socio-economic status, poor housing, limited health food access, and low health literacy all contribute to reducing opportunities for proper health. Thus, health equity is compromised. Evaluating well-being. Client's social isolation and grief because of his deceased family, plus his poor living environment, his hot studios with no windows and without ventilation, may reduce his ability to rest, recover, engage in healthy activities, and might increase his risk for mental health issues, such as depression or anxiety. Allow me to expose some of Tony's barriers to accessing care. By impacting his lifestyle, environment, stress level, and access to care, these social determinants of health represent a plot to increase Tony's risk of uncontrolled hypertension and possibly subsequent complications, thereby creating health disparities. By experiencing a lack of early intervention, access, and support compared to someone with more stable housing, better nutrition, stronger support systems, and better health literacy. Tony lacks a quality job, education, proper housing, and a safe environment, which create barriers to accessing care. Lack of prior regular care, possible inability to prioritize health over working and saving for school, environmental stressors, limited resources for healthy food and home comfort. Lastly, poor understanding of healthy conditions and disease management. Let's move on to show strategic planning to improve health outcomes. Here I outline practical strategies for improving Tony's health outcomes by addressing his SDOH, including necessary mental health screening and anticipated resources, and then reflect on what changes might lead to different outcomes. For instance, we should conduct screening for social risks, housing quality, heat exposure, food insecurity, and social isolation, concurrently with screening him for mental health. Given his loss of family and isolation, tools like the PHQ-9 for depression and the GAD-7 for anxiety are all appropriate. Another intervention is patient education and healthcare linkage. Then I explain hypertension clearly, what it is, why it is important, and what can be done. Establish an ongoing primary care relationship with an NP rather than episodic ER use. Next, community resource and healthcare connectedness. Because his budget and environment contains limitation, I'll link him with programs such as food assistance, health food boxes, affordable housing, or utility assistance for cooling, ventilation. Grief supports groups and social engagement programs. In addition, I recognize positive assets. He bikes to work, build on thereby encouraging dedicated time for physical activity, promote sleep hygiene, especially given a hot no-window apartment, introduce stress management techniques also. Clinicians may explore resources. Tony will benefit from a social worker or community health worker who can help him navigate programs, a dietitian for health eating on a budget, and mental health counseling to address grief and isolation. Best workers' ability to assess the home for cooling and ventilation, a home BP monitor, or clinical visits for BP tracking. What factors would make Tony's circumstances different, and why? If Tony had a stable housing with proper ventilation and temperature control, his risk of headaches and hypertensive stress from heat would be lower. If he had a stronger social support network, family and friends, he might cope better with stress and grief, adhering more to health behaviors, and have better health. If he had higher health literacy and regular access to preventive care, his hypertension might have been detected and managed earlier. If his income was higher or his job had more health benefits, time flexibility. He could afford healthier meals, cooling at home, and early healthcare visits. If he lived in a neighborhood with access to fresh produce, safe spaces for recreation, and lower environmental stressors, his overall health outcomes might improve. Yes, he can be introduced to innovative approaches currently available, as experts validated. Healthcare organizations are pioneering more inclusive approaches to stop food insecurity by implementing food-related interventions into clinical practice. For instance, through partnerships, they provide clients with immediate access, health food via food pantries and food pharmacies without reliance or external referrals. In addition, dietitians and nutritionists educate and guide consumers on managing their health using proper nutrition. There is also the food prescription program, which encourages clients to make healthier food choices, promotes health and healing, and reduces disease burden. Community partnerships are great resources outside the healthcare sector. Meals on Wheels meet patients where they live. Local food banks, non-profit organizations, and government agencies collaborate with healthcare organizations to connect clients with food resources. Let's reflect on the role of the nurse practitioner in addressing social determinants of health and advocating for health equity. As an NP, we're not only providing direct care for hypertension, but we must assess the whole client's context, living circumstances, work, social support, nutrition, mental health, because SDOH influence these outcomes. We screen for social and mental risk factors, coordinate, and refer to appropriate resources such as social work, nutrition, house assistance, and more. We also educate and empower. Many patients like Tony may not fully understand their condition or what they can do. We translate complex medical information into actionable steps and support them in navigating barriers. On a broad level, we advocate, collaborate with other sectors to maximize patient support and alleviate illness burden. Evidence-based practice concepts related to the case study. It is important to underline that Tony is a victim of a tragic house fire, whereas all his family members died. New and all pointed out that burn incidents and injuries are a major public health concerns globally. The existing evidence base shows social and economic factors associated with risks of burn injuries and poor outcomes. It urges healthcare providers to adopt a framework including the social determinants of health as the principal when treating and studying the patient population. Next, researchers advocate that loneliness is a significant public health issue that may impact healthcare costs in the US. It is recognized as an SDOH by the WHO, World Health Organization, and in the UK. Tony says, I really don't socialize too much. a few years ago. And studies show the negative impact of loneliness on the cardiovascular system. They also observed that social isolation adds risk to hypertension and high cholesterol disease. To add, consistent findings reveal that stress contributes to loneliness and depression, and this multifactorial interconnection with stress and loneliness clearly leads to poor health and negative outcomes. Tony eats fast food leftovers. According to Moss and Shear, food insecurity exacerbates healthcare disparities and chronic disease. Individuals with limited access to health food options often miss appointments, delay care, or find it hard to comply with treatment. These problems can easily lead to high cost utilization of care and ER visits. Pearson suggests strategies to healthcare providers to operationalize SDOH assessments. Insert SDOH screening in the EHR system, training clinical staff, establishing referral networks, and monitoring and evaluating outcomes. In this final part, I'll briefly discuss some challenges and opportunities for resolving SDOH in clinical practice. Challenges include limited time in visits to cover social determinant of health and clinical issues, limited availability of resources such as affordable housing, cooling assistance, also fragmentation across health social services. Sometimes it's hard to navigate patients' priorities by working long hours and saving for college like Tony. That may limit engagement and systemic issues. For example, lack of reimbursement for SDOHs, screening, coordination. Now let's see the opportunities. The opportunities are significant. We can integrate SDOH screenings into the clinical workflow, for example, with a brief questionnaire, develop partnerships with community agencies, use telehealth or remote monitoring for patients who reduced mobility or time, and track outcomes. For example, BP control, decrease ER visits, to build the case for more SDOH investment. By addressing social determinants of health through clinical practice, we move toward health equity, ensuring that consumers like Tony, who face multiple social disadvantages, have the same opportunity to thrive as someone with more resources and support. In summary, this case study illuminates how multiple social determinants of health converge to affect Tony's physical health, with hypertension and headache as uh, the chief complaints. Healthcare utilization, delayed acute care rather than preventive, and overall well-being, isolation, and limited resources. As an NP, we play a vital role in recognizing these vulnerabilities, bridging clinical care with social support, advocating for our patients, access, resources, and working toward health equity. While there are real challenges, resource constraints, time, systemic barriers, there are also strong opportunities to make a meaningful impact on both the individual and the population health levels. Thank you all. Solange Peniche. Please see all the references for my case study presentation, and thanks again.